Thanks, Ralph and Joe, and all of you for showing up today. It's really, I'm looking forward to this conversation. I hope this initial session will be a conversation. I'm hoping to only talk through about half of it and then throw it open to you to get your thoughts about what you think are the central issues that you hope are addressed over the next day and a half. This has the name workshop in the title, and it's only a workshop if we actually work together. So in the design of the workshop, we allowed a lot of time for back and forth after each session, and it seemed most appropriate to do that right from the start. So as I'm talking, think about what you think or hoped would be addressed when you came here today. We thought of going around the room and doing that, but we realized we'd have too little time and too many people, but I think we should be able to hear from a fair number of you. So I'll just start this off with this question, which is with regard to observational studies and patient-centered outcomes research, what are the right questions? Let's see if I have this. So too often this has been posed in very simple binary terms, and it's a war that is fought on many fronts. I thought you can only do justice to the complexities of these sort of discussions if you turn sometimes to literary devices. So I borrowed from one very famous introduction to a book of similar complexity. Let's see if I can get this. Let's see, does this work? Oh, I have the wrong one. Remote for the remote. Okay, Tale of Two Cities, and often the wars between observational studies and RCTs does seem like the two completely different people are coming from two different places. So here we are. It was the best of times. It was the worst of times. It was the age of clinical trials. It was the age of observational studies. It was the epoch of data mining. It was the epoch of pre-specification. It was the season of discovery. It was the season of decision. It was the spring of effectiveness. It was the winter of harms. We had truth before us. We had lies before us. We're all going direct to causality, or we're all going direct the other way. In short, the period was the present period, and some of its noisiest funders and policymakers insisted on its being perceived for good or for evil with a superlative degree of scientific rigor. I'll have to apologize to Dickens for that. But this is often captures some of both the complexities, but also our inability in many ways to resolve these the different positions. And we see these almost daily. And whenever I give talks on the potential weaknesses or strengths in the scientific literature, I never have to worry about not having enough sources. I just have to click on the latest health stories from CNN or you know what or anything, and I have grist for the talk. But I have to say, nothing quite was as much of a gift as a paper I saw just yesterday appear. I don't know how many of you saw this on Slate. This is just from the Tuesday. It says, walk, run, don't walk, don't run, walk. It says, flip-flopping advice on exercise may not be as contradictory as it seems. But you have to, here's the text. If you're a runner, you might have noticed this surprising headline from the April 5th edition of The Guardian, brisk walk healthier than running, scientists. Or maybe you saw this one, which ran in Health magazine the very same day. Want to lose weight? Then run. Don't walk. Study. It says, both articles describe the work of a herpetologist turned statistician, so much for snake oil, at the Lawrence Berkeley National Lab named Paul Williams, who this month achieved a feat that's exceedingly rare in mainstream science. He used exactly the same data set to publish two opposing findings. Yeah, pretty much. Well, it doesn't get any better than that. So it turns out that each one was looking at different endpoints. One was looking at one surrogate endpoints, lipids. The other was looking at weight loss. But in terms of the bottom line, which is what PCORI is supposed to be interested in, and patients don't, well, they might care about weight loss, but ultimately they hopefully are interested in whether they live or they die and how long. It's very unclear on what they should do. And this is an interesting conundrum. Now, this is a more serious headline that, of course, appeared almost a decade ago with the results of the WHI, with the implication that something went profoundly wrong, mainly actually with the observational studies that preceded this. And this is a long media exploration of what is, in some sense, wrong with depending on observational studies for health advice. And WHI, in many ways, has been a touchstone for why RCTs are needed. Now, what got less play is what I think is one of the most important papers in epidemiology in the end of the last century, which is Miguel Hernan's paper, who is here. Is he here right now? We'll be talking. Oh, there he is. Okay. Which took the observational data and reanalyzed it. And reanalyzed it in a way that made it a lot more similar to the type of analysis that we do in clinical trials. And there were a huge number of insights to be derived, both from the methodology, but also from the conceptual framing that was implicit in this paper. And this pairing, I think, teaches us a lot of lessons for today, which is that observational studies and RCTs are getting closer and closer and closer. And the choice between them is really not, in a sense, a choice between them, but involve a lot of complicated trade-offs and questions about what each one reveals that the other one does not. Now, there are many sciences that have sort of touchstone equations. Here are some foundational equations. E equals mc squared, Einstein. E to the pi I equals -1. This, I think, is the most marvelous equation in mathematics. How many of you have seen that before, by the way? Just about half. How many have not seen it before? About half. Oh, so it's an honest audience. So this uses almost every important number except for 0 in mathematics, and it relates them all anyway. I won't go through it, but I just sit in awe of that equation. Then there's this. You can say, see, I copied it off the web. Heisenberg uncertainty principle, and then there's a Schrödinger wave equation, and it's a little not appreciated that epidemiology actually has its own foundational equation. It's often accused of not really being a science, but here is the foundational equation I would submit of epidemiology, courtesy of Judea Pearl and others, which is that, and it really should have a question mark over the equal sign, whether the probability of a given outcome for a specified observed covariate, whether that equals the probability of the outcome if you set the covariate equal to some number. That is, if you see a particular outcome when somebody is treated with a particular medicine, is that the same as if you actually actively set the treatment if you manipulate it, basically. So is the observed effect the same as the effect you would see if you actively manipulated the variable? And that's the foundational question. And if this is true, then we have, in a sense, transference of the observational result into the realm of practice. In English, well, I should have put that up there so I could have just read it. The probability of an outcome when you observe a risk factor is equal to when we set it. I will say that this equation does not specify how one sets the variable. And I think Miguel will probably make this point. If you talk about weight loss being produced by liposuction, amputation, or exercise, those are three profoundly different ways of affecting one's weight, with very different ways of expected outcomes. So this is a cartoon that many of you have probably seen, but it's so subtle and wonderful that I thought it's worth putting up here because it embodies a tension, I think, that, again, underlies this meeting. So you have this little one person talking to the other. I used to think that correlation implied causation. Then I took a statistics class. Now I don't. Sounds like the class helped. Well, maybe. And it's funny, but it actually is very, very interesting because it's an N of 1. There are no controls. And yet there's something about this story that makes us actually believe that if somebody went through a class and had this transformation of their belief, that it was due to the class. We actually believe it. And the question is why? So this is the worst kind of observational study. So, but we laugh because we see that we ourselves are falling into that, I don't want to say falling into the trap, find it compelling. Now, I've been involved in the production of 2 reports over the past year, one through PCORI and one through the Institute of Medicine. And I thought I would just reflect on them very, very briefly, because in both of them, we were posed really the same challenge that we are here to discuss today. This is for the first one is the Ethical and Scientific Issues in Studying the Safety of Approved Drugs. It was commissioned by Peggy Hamburg and Josh Sharfstein, who was then with the FDA, in the wake of the Avandia issues at the FDA. And the question was posed more generally, which is, and I'll focus on the second and third parts of our charge, what are the strengths and weaknesses of various approaches, including observational studies, patient registries, meta-analyses, patient-level data meta-analyses, RCTs to generate evidence about safety questions, and then number 3, which is really the tough one, considering the speed, cost, and value of studies, what types of follow-up studies are appropriate to investigate different kinds of signals, and in what temporal order? Now, I'll let you think about how you would answer that question. I'll show you briefly how we did. I would say that one thing we felt compelled to do was have a whole section on why experts disagree when looking at the same evidence. And this is a partial response to the idea that you could have a formulaic, algorithmic way of approaching exactly the sequence and combination of studies to be done. Because if you can't agree on a study with the data right in front of your eyes, it's going to be very, very difficult to think about what exactly is the sequence of studies going forward. So we highlighted a whole bunch of different reasons why experts disagree. And I think there is some sort of, and this is not necessarily on the part of the FDA, but in the general community, sense that somehow scientists will all agree. People presented with the same evidence will all agree. And if you acknowledge that that is in fact not the case, this opens up extraordinarily rich and different kinds of conversations about what the best way is forward. So we divide this into these different categories. There's disagreements about prior evidence, lots of disagreements about what feeds into the quality of a study, both existing ones and the ones going forward, going from disagreements about the reliability of the data source, the design, and the appropriateness of the analysis. There are different views about whether the new evidence is relevant to a public health question, both in terms of the questions asked and the transportability of results, different ideas about which studies can be combined, and there are different notions about what the appropriate regulatory response is, which often tracks backward and affects people's evaluation of the evidence. So this was our starting point, that good scientists will disagree about the data in front of them. And in fact, I've often said in other settings, if one trains doctoral students, I would say an entire doctoral career, if you understand all the issues brought up in the 2-day hearings that were held on Avandia, that's a course, that's a doctorate in epidemiology. And I've encouraged several directors of programs to just use that for a full year's curriculum, because it's unbelievable how many issues were raised there simultaneously. And in a really somewhat rare, although Bob will tell me probably not, Bob Temple, display, all the differences among staff at the FDA were allowed to be aired in this hearing. So that's what made it quite interesting and in some ways dramatic, at least in terms of public theater, which is one staff member standing up and one scientist contradicting sometimes a colleague, maybe in the next cubicle, certainly in the next building. And they were all legitimate ways of looking at the evidence. We talked about how to decide between an observational study and an RCT. We really came down, of course, with the same sort of idea that Ralph put forward, is that, rarely should we be seeing this as a binary decision, and these things can coexist. And it's a very complex decision and has to do with the size of the signal, the size of the effect you need to detect, the time urgency, other confounders, the quality of the data, the transportability that you need, and the issues of the analytic approach. Now, PCORI, which is established, here's the establishing legislation. What's interesting about this is how big the words Congress and Act are, and how tiny the words Patient Protection and Affordable Care Act are. This is typical of Congress. But this is what established the Methodology Committee, and it set as our mission two things. One is to set methodologic standards for research. And we've had lots and lots of discussions about that and about whether these should be best practice standards and aspirational standards or minimal standards, but I'm not going to really focus on that here. The second was that we develop a translation table that's designed to provide guidance to the board to determine research methods that are most likely to address each specific research question. Well, you'll see that this is remarkably similar to the charge of the other committee, and you won't be surprised to see that we came down in a way that was not so different, where we proposed a translation framework as opposed to a specific algorithmic way to address this. Many of the factors on this list are quite similar to what the other committee came up with. And this is how basically all those factors appeared prettied up in the report with lots of arrows, et cetera. And all these things have to be combined really with folks with expertise that knows how to handle the gray areas. Now, what are some of the emerging principles that we said came out of that? One was to keep the research question, the design, separate, to focus on clarifying trade-offs. And this three is quite important, that we talk about decision makers as though they're unitary, but in fact there are many kinds of decision makers, and the information you need at the bedside is sometimes profoundly different than the information that that they need at CMS to decide whether to cover things, or at FDA, whether to approve things. And this is something that I think is, when we talk about comparative effectiveness research being useful for decision makers, there's remarkable heterogeneity, and this does not give you the answer. Put the individual research studies in the context of a research program, so not look at any study individually. And finally, that the study design has to take into account state-of-the-art research methodology. That is, the body of observational research that Miguel Hernan used in that seminal paper was the same body of research that had been analyzed using other methods, and yet he extracted a very, very different message using better methods. So in both of these reports, the role and place of observational research in the world of therapeutics was central. There seems to be a strong need to apply the same somewhat formulaic rules of evidence and design familiar from the EBM world to the observational data world, and this comes in through the demand, in some cases, to create rules or at least a social consensus about what constitutes legitimate designs for various questions. And I would say that the best we can do is articulate principles and have folks discuss them in each case, and not pose it as binary choices based on specific rules. I have two slides on various canards, and this relates very much to Ralph's T-shirt, that have been put forward vis-a-vis RCTs and observational studies. And there's lots of things that are said in hyperbolic and ways about RCTs and observational studies with respect to a whole bunch of things. Bias, the resources that it takes, and I've highlighted the good category in green and the bad one in red. Causal inference, transportability, reporting biases, whether it reflects real-world aspects of practice, whether it's patient-centered, data quality, ethicality, and sample size. And yeah, well, that's an hour. I couldn't think of a better way at 3 in the morning to phrase that. But whether they're ethical tensions embedded in the design. So I'm not going to go through each of these. All of you recognize that there are sort of extreme positions with respect to each of these, and they tend to be caricatures of reality. And I think it's really important in the workshop today that we don't put ourselves in one of those camps that say that observational studies are generalizable, RCTs are not. That observational studies give you highly patient-centered, individualized evidence, RCTs don't. For every one of these, you can cite a design or way to modify the other kind of design so you can get very, very close, if not better, than the other design. Then there are methods canards, which are new statistical methods solve the inferential problems of observational studies. It's not true. Large amounts of data can overcome the problems of poor data. It's not true. Electronic health records make high-quality observational research much easier. It could be true. Right now, it's not true. The more personal the data, the better the prediction. The better prediction means better outcomes. I would submit that none of these are true, and most of the people in this room know that, but a lot of the people not in this room don't. What is true is that the distinctions between observational studies and RCTs can be subtle, particularly not just as you get to day 2, but 3, 4, month 10, year 3, etc. Interventions are changing, and they're getting more complex. We have not just more data, but different data types and much more complex data with the linkage of different sites and use of biometric data, iPhones, you name it. It's very different data and genomic data. We do have new improved methods, absolutely, but they may or may not be keeping up with this rapid evolution in the data types and designs. We have new outcomes, we have different decisions, and then we have a lot more emphasis on transparency, reproducibility, and wider engagement, and this has implications. So the basis for the meeting plan today, we actually had a conceptual framework, and it was based on this sort of simple but conceptual framework, which is we have the true effect in the study setting, and then you have to the left the difference between that and the effect in practice, and then to the right we have the bias, the average effect measured in the study design, we have random error, and finally we have subgroup effects. So what we, there we go. So what we actually measure in the study that's as personal as possible may be very, very far from the effect we see in practice. And we have sessions on each component of this, the bias, the subgroups, the generalizability, and also prediction. So this is sort of the simple framework in back of the program. The central questions I hope we will ask, and I'll be interested in hearing more from you. Does the method we talk about address the question we're really interested in? Does it estimate the effect correctly to those for whom the results are applied? If not, how wrong could it be? And does it get the uncertainty right? And if not, how wrong could it be? Which of the approaches, this is the more fundamental one, which of the approaches discussed today and tomorrow would be sound enough to guide a treatment decision? Would you bet a life on it? And if not, could they get there, and what would it take? And finally, these are the decisions that face PCORI, and I hope we keep these in mind. Which methodology should be used and how? And that's for investigations planned today. And finally, and this is something that keeps Joe up nights, and Larry and others in the room, investment in the development of which new methodologies will yield the greatest benefit. And these are technologies in terms of measurement, design, analysis, data generation, and decision making. And which of the methods should the next generation of PCORI researchers be taught? So with that, I will stop and throw the floor open to you. And I think we have until 9, so we have about 25 minutes for this conversation. So we actually have some folks who are prepared for this from the methodology committee. They weren't prepared for my remarks, but they were told that they would be there to warm up the crowd and offer their wisdom. So we have Sally Morton or Dave Meltzer. You can kick it off first. You can decide between yourselves.